So good afternoon. I'm Dr. Boon Chua. I'm a radiation oncologist and the radiation oncology lead of the breast cancer trials ANZ. It's my pleasure to welcome Professor Julia White, one of our international guest speakers. So Julie is the Professor of Radiation Oncology at the GEMS Comprehensive Cancer Center at the Ohio State University. And she's also the Vice Chair of the Energy Breast Cancer Committee. So welcome, Julia.
Thank you. Thank you for the invitation.
Right. So you'll be delivering 2 lectures in a conference this year. And the first one is about partial breast radiation. As you know, many patients would receive whole breast radiation after breast conserving surgery, namely those patients with early breast cancer. Could you explain what partial breast radiation approach is, given the keen interest that it has been attracting in recent years?
Sure. So partial breast irradiation it focuses the treatment after breast conserving surgery, or which I call lumpectomy. Instead of treating the entire breast, which is really what's been done since breast conservation came into existence in the 70s and 80s, it looks at just treating the area immediately around where the surgery site has been. So if you think about it, it's about 25 to 30% of the quadrant of the breast bearing the tumor. And it's really based on the fact that when you look at the women who do suffer an in-breast recurrence, either after lumpectomy alone or lumpectomy or radiation, the tendency is for cancer occurrences to come back around the immediate site of the surgical excision, within a centimeter or so of that. So it's really aimed to say, do we need to, if the incidence of recurrence after breast conserving therapy is so low in quadrants away from where the tumor was, do we really need to irradiate it? Can we just go sort of more aggressively at that lumpectomy site and get comparable outcomes to whole breast radiation? Now, the big advantage, in the States, it's really been researched as being an accelerated course, something that can get done in under 5 to 8 treatment days. I know there's other parts that look at partial breast irradiation over 15 days. And that's really not been our focus for the most part, particularly within energy oncology. We have a large NSABP RTOG trial of 4,200 women, and in that case, all the women were treated twice a day for 10 treatments over 5 to 8 days.
So it would seem like these accelerated course of radiation would mean greater patient convenience. Yes. What are the benefits may there be?
So I think we are still, our quality of life data was just presented at the ASCO meeting last month. In analyzing approximately 1,000 women who had, and we divided it by who received chemotherapy, who didn't receive chemotherapy, and asked the patients the questions of, what was the experience like? What was the burden of care? What was your level of fatigue? And what we found is that women who went through accelerated partial breast irradiation really demonstrated less stress related to burden of care. In addition, and particularly the women who did not receive chemotherapy, I think when you receive chemotherapy on this clinical trial, it has its own level of toxicities that it brings. But for the women who did not receive chemotherapy, burden of care and fatigue was much less with the partial breast irradiation. So I think that we've at least proven that with our quality of life studies on our large NSABP RTOG
So would
trial.
these partial breast radiation approach be suitable for all patients with early breast cancer?
So I think that's been the big question, hasn't it? So which patients is it equivalent to whole breast irradiation? There, as you know, have been several randomized trials now helping us to identify which women would be best for this treatment. And 3 of the trials so far that have come have really shown non-inferiority to partial breast irradiation. But you really have to look at who was in those clinical trials. It's really been women who are predominantly postmenopausal. Nearly all of them have had hormone-sensitive breast cancer and have taken an endocrine therapy for treatment for 5 years. It's mostly grade 1, 2, and almost completely node negative. So that's really the population that this is targeted for. We, within our trial, our large NSABP RTOG trial, asked a question then, could this be translated to all women? Could all women, after lumpectomy, get a partial breast irradiation course so that essentially you wouldn't need any whole breast irradiation? And when we looked at that, and our population was younger, more node negative, more node positive, we had some ERPR negative patients in there, high grade patients in there. we demonstrated that it's not quite equivalent to whole breast irradiation. So it's not for all women who undergo breast conserving therapy, lumpectomy, but certainly for a large percent of our population, hormone sensitive, postmenopausal, node negative. When you look at the subset analysis, which were exploratory in our study, the in-breast recurrence rates were between 2 and 3%, whether you had partial breast or whole breast radiation at a median follow-up of 10 years. That's amazing success for local control in the breast.
Well, that's good here. Where did most of these in-breast recurrences occur in your study?
So it's interesting. So most of them, again, occurred around the lumpectomy site. But when we looked at, and this was, again, an exploratory, this was not a pre-specified endpoint of the trial. So we have to be very, very careful when we discuss it. But when we looked at where patients who did not get whole breast irradiation recurred, they were slightly more likely to have occurrences outside of the tumor-bearing quadrant. That's why for the breast cancer subtypes that have higher event rates, ERPR negatives, I think it's debatable whether it's HER2s, but they're not well studied. High-grade lesions, young women, they all are known to have higher local regional event rates. Those are women for whom you probably still want to use whole breast irradiation still. But quite frankly, if you look at stage 1 breast cancer, it's the most common cancer diagnosed for women. The vast majority of it is ERPR positive and HER2 negative. And postmenopausal breast cancer is the most common breast cancer we diagnose. So there's a lot of women, I would say tens of thousands of them each year who could benefit from getting partial breast irradiation and reducing their burden of care with the radiation.
Yeah, so it seems like that more research is warranted, especially in the area of selecting the right patient for this particular approach of partial breast radiation, do you think?
So I think I think that the trials, between our large trial looking at everyone and seeing if you can replace whole breast radiation, and the 3 trials that were successful non-inferiority trials in predominantly grade 1-2, stage 1, which is node negative, hormone sensitive patients, really, I think, tells you that that's the key population for partial breast irradiation. I think there's real room to identify what's the best dose fractionation schedules. I personally, in my own practice, still use the 10 fractions twice a day. That's burdensome for patients and for on the technical staff at centers. There are fractionations such as used at New York University and the University of Florence trial, where they've done 6 gray every other day for 5 days. So I think there's opportunity for research in that in there as well. There's been some controversy about the cosmetic outcome after partial breast irradiation. The RAPID trial, at San Antonio, at a large meeting, reported that they had inferior cosmetic outcome. The quality of life data from the B390413, our large trial from Energy Oncology, really showed very overall, using a scale of 1 to 5, about 1 to 2 is what's scored by women, and really minimal changes from partial breast irradiation that you would wonder if there's any clinical relevance to it compared to whole breast irradiation. And we are going to report our data on cosmetic outcome using photos and patient and physician assessed at ASTRO, our upcoming meeting. And I can, I can tell you that our data follows our quality of life data. I can't tell you exactly because it's embargoed, but there will be no surprises. It's going to follow our quality of life data, so minimal changes. So I think every institution has to figure out their best practices that give women nice cosmetic outcome as well.
Yes. So what do you think account for the differences in the cosmetic outcomes between the Energy trial and the Canadian RAPID study?
So you have to look at when those trials started. So remember when accelerated partial breast irradiation was being investigated, our trial started in 2005. That's a long time ago. And shortly thereafter, the RAPID trial also began. It was new technology back then, and we have to keep in mind that radiation delivery is operator dependent. So for many investigators, the first time they've ever done accelerated partial breast irradiation was on those trials. So I think that as in all things in medicine, as we become better practitioners at it, we get better outcomes. So I would advise women who are interested in partial breast irradiation, accelerated partial breast irradiation for convenience of care, that they really talk to their practitioner, ask them how often they do it, what are their cosmetic outcomes. Every institution should have that available for patients. And you know, you need to understand that not everything is equal at every place. And you have to be mindful to not over-irradiate too much of the breast, and to watch your timing of your dosing if you're doing twice a day. So I think those initial trials were done a long time ago. I think we've learned a lot, and I can't help but wonder if they were run today with our current knowledge, whether you would see as big a difference you see in the rapid trial.
Well, yes, I mean, there's certainly the factor of the learning curve. And also, I think when we talk about the adverse cosmetic outcomes of some of these patients straight on study and likely off study as well, we are predominantly talking about the partial breast radiation approach using what we call the extended beam radiation, which is the most widely available technology that could be used for this approach. What other approaches there be? Do you think that may circumvent some of these problems of adverse cosmetic outcome, you think?
So I don't know. I honestly don't know. So our data for cosmetic outcome with photos will be about 90% of it is in our 3D conformal radiation. On our trial, 75% were done with 3D conformal radiation. And so I feel pretty confident that our data that shows minimal impact and change from partial breast irradiation represents 3D conformal radiation therapy. I think we have to be mindful of brachytherapy approaches, such as with a single entry device that was popularized in the last decade, or individual multi-catheters. We have yet to see the cosmetic outcome from the JAK-ASTRO trial. They've had good cancer control outcome, but we have yet to see the cosmetic outcome from that. So I would caution patients that the delivery of radiation, like a surgical procedure, is operator dependent. Your doctor should know what their cosmetic outcomes are from this, and that's if you're looking for a less burdensome radiation for partial breast irradiation, you should go to a center that you know has those outcomes.
That's right. So we talked about partial breast irradiation approaches using what you mentioned. It was the 3D conformal radiotherapy. So that is a form of extended beam radiation. You also talked about the multi-catheter brachytherapy approach. What do you think of the approach of partial breast radiation using intraoperative radiation?
So I think that is. I think that is an area and a technology that is clever. It certainly reduces burden of care. It's one-stop shopping. You know, you get your surgery and your radiation at the same time. But I'm not 100% we understand yet where that's going to be the most useful. And I think the jury is still out. I think they've done the heavy lifting of organizing these really wonderful large trials. But the median follow-up in a predominantly hormone-sensitive breast cancer that's node negative is too short. As you and I know, we within Energy Oncology waited a median of 10 years, 10.2 years to report our outcomes, because that's the natural history of the disease that we work with in hormone-sensitive. That's what's meaningful. So I'm not sure yet. I think the jury is still out whether intraoperative radiation therapy for partial breast irradiation alone. I think that there are women who we have to be sure when you're using intraoperative radiation therapy that you understand the patient's stage. So women who do want to have that type of treatment should make sure, if they're having a sentinel node biopsy, your surgeon waits for a frozen section to find out whether you're node positive or node negative, because that final information is important for your cancer control. And at least in the States, that's done less and less, waiting for the frozen section on sentinel node biopsy. So you have to understand the stage of disease, confirm that it's node negative, and that's what I personally think makes you a good candidate for partial breast irradiation. And that's part of the rub with using intraoperative radiation therapy.
Right. So just to follow up on your earlier comment that the in-breast recurrence rates have been falling over the last 2-3 decades or so and continue to do so. Do you think that all patients would require radiation of any sort after the surgery for the early stage disease, you think?
I think that is a really exciting area. I really do. So I think that when we started breast conservation 50 years ago, right? We didn't understand that not all breast cancers are alike. As we understand the biological heterogeneity of breast cancer and understand subtypes, I think that's where our opportunity for individualizing a treatment approach for breast conservation. I think what's really remarkable, if you look at the B390413, our large partial breast irradiation trial with over 4,000 women in it, at a median follow-up of 10 years, the event rate in women who got whole breast irradiation therapy, the in-breast recurrence is 3.9%. Think about that. That is 96% have local control at 10.5 years. And remember, roughly 15 to 20% were node positive, 18 to 20% were estrogen progesterone negative. We had a nice representation of intermediate and higher risk patients in that. So it's really good news. So the question then, it's really time to say, can we identify patients for whom their breast conservation should be their surgery? That's it. We don't need to say that breast conservation is always surgery and the breast radiotherapy afterwards. And for me, again, I think we have to go back to breast cancer biology. And I think luminal breast cancer, that's hormone sensitive, and for most part, we believe this is luminal A breast cancer, that is hormone sensitive, HER2 negative, and mostly grade 1, 2, is that population. I think where the opportunity now lies, and we now have means for identifying these patients, either through a combination of immunohistochemical staining, like the IHC +4 that they're using, plus clinical combination that they're using in the primetime trial, or as you're doing, using these multi-gene assays, these RNA expression assays, that have been really developed for identifying who's at risk for distant metastases. As you know, when they've been applied also to local regional recurrences, are prognostic for it. So far, they haven't told us who predicts radiotherapy benefit. So that's different from distant metastases, because there we have an idea that it predicts that there is not a chemotherapy benefit. But I think it identifies patients who have such a low cancer event rate that for their in-breast recurrence, that we can then identify women who we can say to them, omitting the radiation is going to leave you a slightly higher chance of in-breast recurrence. That's going to be, we feel, acceptable to you. We are going to be able to salvage you with another breast conservation, so your risk of losing the breast is no higher, and we're not putting you at risk for higher distant metastases. And I think that's exactly what your trial does, the expert trial, and that's what we're developing in the United States as well through Energy Oncology. I think it's a very exciting time.
Yes, I couldn't agree more. I've been certainly using the tumor biology, incorporating tumor biology, including the multi-gene assay in refining patient selection for treatment to ensure that these patients would have the best chance of a cure from breast cancer, and yet making the treatment as safe as is possible. That certainly is, I would say, one of the most exciting, if not the most exciting areas of breast cancer research in the coming years. Well, thank you very much. It's been very illuminating talking to you, and we very much look forward to your lecture tomorrow.
All right, thank you very much.